How do I advance the slide? Yeah? This? Okay. Okay. I want to thank the forum for inviting me to participate in this workshop. And I was asked to frame the state of science around the issue of urban health. And this title was actually given to me, so I try to develop my project, the talk, to satisfy this title. So how do I use this? The what? The green button. Okay, all right. Okay, now I know. So can you guess where this picture is from? Can you take a guess? What city? DC. DC? Close enough. This is Paris, 1872. What about this? I took this picture a few years ago. This is Chennai, India. It's in the Saidapet neighborhood. Not much different in more than 100 years later. And so urbanization, as was mentioned earlier, the number of people living in urban settings, more than half the people in the world started living in urban settings as of 2017. And in the, as Dr. Dai mentioned, in the Sustainable Development Program, the word slums is actually used. And so this is the Sustainable Development Goal Target 11.1, access to all to adequate, safe, and affordable housing and basic service and upgrade slums by 2030. And so I agree with Dr. Dai that this is a sort of a target that we need to seek to deal with this issue. And even as early as in the early 2000s, a report came out from the UN Habitat describing the conditions of slums in the world. And I don't know if you're familiar with this report, but this is really the first important documentation, formal documentation of the issues related to urban slums. And they use the term slums. You know, slum, the word slum has this connotation, negative connotation, but it's really been repurposed to really sort of give a sort of an empowerment for the people who live in these kind of conditions. It's an accepted terminology. And so there is actually an official definition of urban slums. So these are demographics, spatial, and economic and legal and social indicators of 1 billion people who live in the slum. That was as of 2003, so there are a lot more people living in these kind of conditions. And so the report studied these characteristics: life expectancy, under 5 mortality, access to improved water sources, and sanitation, slum upgrading programs, and poverty reduction programs. But what was missing were the health indicators, the health burden measures. And perhaps the reason for this is because it's very difficult to assess health burden measures. And so if you use the operational definition of slums, so this is based on the United Nations expert group that met in Nairobi in 2002. So they defined slums as inadequate access to safe water, inadequate access to sanitation and other infrastructure, poor structure, quality of housing, overcrowding, and insecure residential status. And so we use these definitions. The number of people living in these kind of human settlements have progressively increased over the years. The encouraging thing is that the proportion of people living in these kind of settlements has decreased, but the absolute numbers of people who live in these places have steadily increased. So again, if you go to Chennai and if you try to go from the airport to downtown Chennai, you'll see billboards like this. And if you go, especially if you go at night. But if you cross this bridge overlooking this river in the daytime, you'll see the other side of India. And of course, people who are depicted by these billboards, the entire middle class of India is about the size of the entire United States population. So of course, the kind of lifestyle depicted by these billboards are required by that segment of society, but the rest of the population are depicted, as you can see, underneath those billboards. And they require a totally different type of healthcare. And here's another sort of contrast that you can see in Paraisópolis, which is a neighborhood in São Paulo, Brazil. And if you just highlight that section, you'll see this. So you see this kind of housing. There's a swimming pool in each patio there, with the tennis courts and more swimming pools. And this whole, the right side of this fence here, if you try to look at the type of infectious diseases that people on the right side of that fence might have, you'll see acute respiratory infection, you'll see TB, AIDS, etc. And as do people on the left side of the fence. But in addition, you'll see these diseases like leptospirosis, meningitis, all the hepatitis, vaccine-preventable diseases, multi-drug resistant TB. People here may develop TB, but people on this side are more likely to develop NDR TB. Rheumatic heart disease, advanced stage cervical carcinoma, and then microcephaly. These diseases will rarely be seen on the right side of the fence, just because of this one simple division that you have with this fence. And so this led Gita Verma to state the root cause of urban slums is not urban poverty, but in urban wealth. And I agree with Dr. Eze that it's not poverty that's really determined these outcomes in slums. And one of the determinants is really urban wealth. And this is, I think, a very important point to stress. But I want to, since I was asked to frame the science around the issue of urban health in terms of the infectious disease, I want to take the definitions of slum and then see how those definitions contribute to infectious disease and other health outcomes. And so, this is one of the definitions that components of the definition: inadequate access to sanitation and other infrastructure. So, oops. How do I reverse this? How do I reverse? Okay. So if you have increased rat density, that contributes to, of course, leptospirosis and typhus. Open sewers leads to these infectious diseases depicted here: hookworm, leptospirosis, diarrhea, etc. Suboptimal school lead to poor nutrition, which of course are associated with infectious disease outcomes. Inappropriate and inadequate health services. You have poor vaccine coverage, maternal health complications, which includes infectious diseases, underutilization of healthcare services, rheumatic heart disease, suicide and chronic diseases, which lead to chronic non-communicable diseases, and of course drug-resistant TB. Lack of residential infrastructure, such as street lighting and public bathrooms, lead to violence to women and intentional injuries. Dr. Eze mentioned injuries as a biggest contributor to young adult male health outcomes, poor health outcomes. If you don't die immediately of these intentional injuries, you die of infectious complications of those injuries. If you're lucky enough or unlucky enough to get hospitalized for your injuries, you die of either infectious disease or some multi-drug resistant infections. If you take the other definition, insecure residential status, informal tenure and lack of title deed, lack of representation, you're excluded from healthcare services, and then decisions important for the community that affect health outcomes. You may be evicted, leads to poor access to healthcare services, schooling, work. Many of these people who are born in these kind of communities, they're not even recorded, they're not even registered. If you're not registered, you don't get healthcare, you don't get education. And those lead to a variety of poor health outcomes, including many types of infectious diseases. Toxic chemical exposure, poisoning, respiratory disease and cancer, the major causes of death from respiratory disease and cancer, again, are infectious disease. And then low service utilization, you have chronic diseases, unwanted pregnancy, STIs, HIV infection, substance abuse. Overcrowding, all kinds of infectious diseases. I want to try to summarize the last two diseases that we've been studying in Brazil: rheumatic heart disease and Zika virus infection, its congenital consequences. And so rheumatic heart disease is an immunologically mediated chronic complication, group A, of streptococcal pharyngitis. And in the past, WHO estimated the prevalence of disease, and the peak prevalence was estimated to occur in young adult age group, 24 to 35 years. But recent studies from Brazil have suggested that the mean age of severe complications of disease has decreased. So the one study done in 2002, the mean age where children develop congestive heart failure and stroke is 12 years, and another study later showed it was as low as 9 years. And so Salvador, we've been looking at this issue, and we looked at 3 clinics in the city of Salvador: San Marcos, Quinto Centro, Jorge Valente. San Marcos and Quinto Centro predominantly serve kids who live in the urban slums, and Jorge Valente is a private clinic. And we wanted to look at the genetic distribution of group A strep in kids who develop sore throat. And so if you look at the diversity index of the EMM gene sequences, in Jorge Valente, the private clinic, the diversity index was 0.92, and then it was higher in Quinto Centro, and even higher also in the ESM. And there was a paper that was published by Steer et al. Back in 2009, and they showed that in high-income countries, if you look at the EMM sequence, group A strep, in high-income countries, it was actually almost identical to the isolates from the kids who go to the private clinic. And look at these. So the ones from the 2 favela, or the slum clinics, their genotypes were similar to those found in African and Pacific region countries. Same city, and yet, so far, in terms of diversity. And then the ones indicated, the bars indicated in red are those that are in these experimental vaccine for group A strep. And if you look at the Jorge Valente, the private clinic, the most common genotypes are 12 and 1, EMM types 12 and 1, which are also found in the high-income countries. In high-income countries, those 2 are the most common EM types. But if you go to emergency at San Marcos, 12 is here, and then 1 is a little lower, and those together account for just 21%. And if you look at the African region country, EMM1, 12 and 1 contribute to less than 10% of the vaccine genotypes. And then if you look at Quinto Centro, it's even lower. So if this vaccine were to be administered in the same city, you'll have more of an efficacy on the kids who go to the private clinics, but not on the kids who go to the favela clinics or slum clinics. And so we talk about disparity, but there's already disparity at the cellular level here. And that's, I think, the point that I want to make, that we need to do the biology to really understand. If we're to come up with a vaccine, we need to understand the biology as well. And also the Zika virus. So look at this picture again. In each of these little boxes you see here, there are probably about 10 people living in each of those little houses. And so when the infected mosquito comes into this side of this community here, the virus is an RNA virus, and is highly likely to undergo diversification. And so the people who are infected on this side, on the right side of this fence here, are more likely to be infected with a higher diversity of Zika virus clades than the people who live on the left side. And we hypothesize that may be one mechanism for the higher occurrence of the microcephaly and the congenital Zika syndrome that we see in the favelas, in the slums. And so in February 2016, WHO declared a public health emergency of international concern because of the congenital syndrome. And then, but later in the same year, WHO declared an end to this public health emergency status. And in Brazil itself, earlier this year, declared an end to public health emergency of the Zika epidemic. But for a young mother like that, and her mother like this, and families like this, it's really only the beginning. We don't have the Olympics right now, and travelers to these countries are less likely to get infected. But this is not the end. This is really just the beginning. It's a nightmare just beginning for these people who live in these slums. And so let me just end. Say we can't wait for alleviation of poverty, disparity, and inequality. We can't wait for social capital development, technology transfer, UN Sustainable Development Goals. So this is my opinion and Sustainable Development Goals. We have to do something now to really formally recognize the existence of this population. That's number one. We need to know, everybody needs to know that there is this type of human settlements in this planet, which right now is in excess of 1.5 billion people. We have to work with the residents of slums to assess burden of disease in this population and develop new metrics. And we call this precision public health research to measure biological, sociological, and environmental determinants of disease and provide data for national governments and identify and implement novel interventions specifically designed for slums and get those in position of influence to set the priorities straight. So let me just end by this quote. The main stock exchange go up or down 3 percentage points, and this is a world event. This cannot be. It's time to flip the tortilla. You know who said this? He's the only pope that I've ever quoted in talks. So let me just also tell you about what we're doing from the science perspective. So we have this program called the Global Health Equity Scholars Program. This is a training grant funded by the Berkeley International Center. And this is a program that our consortium includes Berkeley, Yale, Stanford, and Florida International University. Albert Koh, who's here, is a PI at Yale. And we trained US-born fellows and LMIC fellows to work in one of our 30-odd sites to really get into the issue of slum health research. And so if any of you are fellows, you're welcome to apply. The deadline just passed. So let me just end the acknowledgement of all the people who've participated in these projects over the years. And then just an advertisement. So Jason Corburn, who's here, and I came out with this book last year, last year. And we call it From the Cell to the Street because I do the biology, and then Jason does the street science. Okay, let me end.
Thank you so much.